appreciate the invitation. It's nice to be here. This is somewhat like part 2 to the first talk that I gave yesterday. Yesterday well, before I guess I'll give my disclosures. So I am a proctor with Intuitive for the last almost 10 years, and that's in that role I served as a proctor, which took me in several different countries. These are my other disclosures. Yesterday we talked a little bit about robotic surgery and its evolution and how it started in the United States and is spreading globally. And it continues to rise in the United States, but it's really rising at a much faster pace in other countries, whether in Europe, in Asia, in the Middle East, and now taking on to Latin America and some African countries. And I think it's important to, yesterday we looked at reasons why I thought it was rising in certain countries, geographic regions, but now I'm going to speak about the training that comes with it and the role that we have, as many of you in the room are robotic surgeons as well, as we have in the United States to train other surgeons in other countries, and how can we do it and how can we do it effectively. Robotic surgery, as we talked about, has been FDA approved since 1999, so now over 25 years that it's been around. And I had the opportunity to be in the earlier part of the learning curve since 2010. We talked about already the rationale, and when we talk to people around the world, is that this is just a tool. This is, as we mentioned, a luxury niche. This does not change gross healthcare outcomes in countries, but in certain situations, in certain health systems, in certain types of patients who can afford it, there is a benefit to doing robotic surgery for the reasons that are listed here and that many of you know. I think one of the important ones is about standardization of instruments. We talked about how you may not have the instrument that you like, but right now with the company having the greatest lion's share of the market worldwide, one company, Intuitive, all the instruments, no matter where you go in the world, are going to be the same. So if you are doing proctoring in Japan or in Dubai or in Brazil, you're used to the same instruments everywhere, and there's something to be said about that. Of course, there's going to be miniaturization of the instrument, but the most exciting thing, as I mentioned last time, is that the computer interface and the software, which is going to allow us to do teleproctoring. Many of us talked about this yesterday, and eventually be able to do integrate artificial intelligence and do telesurgery. So we already talked about how it was mostly in the United States, but you can see that now it has taken off in Europe for reasons we talked about yesterday, and Asia. And there are over 66,000 surgeons trained globally. And there are over 80 centers globally for training in thoracic surgery, well, in robotic surgery. So it started, we mentioned yesterday, for those who were not here, that I believe that it started off in the United States and it's the biggest market just because we're a center for innovation and startups. It's a larger and more profitable potential market for companies that are starting off in healthcare. We have a very robust private system, because that makes the difference, that has very high expenditure, price elasticity, and then the patient expectation. But in some countries I get invited, or some of the surgeons that I meet at different places say, well, we want to get robotic surgery, and we do have one robot that's sitting in the capital city that's not being used, or we want to get a robot now in our secondary city. And what are some of the barriers to adoption? And to me, the biggest one, that's obviously, is cost. Whether it's the cost that gets passed down to the organization, whether it's the cost that gets passed down directly to the patient, whether it's the cost that gets passed down to a public health system that's for a whole country that has to be homogeneous. So you can imagine That's very different. If you're running a whole national healthcare system and you have robotic surgery in one place and you offer it in one place, there's going to have political pressures, social pressures, to have it placed in all your different areas of your socialized healthcare system. Also, for smaller places, it's private hospitals. Some of these private hospitals, for example, where I was in Lebanon, are owned by families. So much smaller pockets than a full national healthcare system. So the cost is a big thing. But the other big thing is that you may buy the robot and then it breaks down, and maintenance is another thing. Third barrier to adoption is geographic access. You may put it in one city, but you have a very, very large country. How are you going to get patients from one city to get to where the robot sits? And lastly is also surgeon training. Not only training the surgeons, but who are you going to train? Who's going to fight amongst each other to be trained? How is that going to be in terms of economic pressures between the different surgeons? So that plays a role as well. So I'm going to go through these barriers, and when I speak to the local surgeons, or I speak to administrators, or I just think about how best to help my colleagues, I try to break down these barriers to adoption of robotic surgery, because I do see value in the technology. The cost. First is that the cost is divided into capital cost, purchase of the $2 million robot, and then the disposable cost. So in terms of the capital costs, there is going to now be competition in the marketplace. There already is with Medtronic, but there's going to be other companies that are going to be coming in, other companies made in different countries that will definitely, in my opinion, bring down the cost. Sorry. The second is reusables. We have instruments that have only 10 lives or 20 lives, and that can change. You buy an espresso machine, then you say, great, I got it for $150, and then little do you know that your capsules are what is the biggest cost over time. But now there's generic Nespresso capsules you can get on Amazon, and sure, they don't look as nice and it doesn't have all the different things, but they certainly work, maybe not as well, but they certainly work in your Nespresso machine. And I think that's what's going to be the future of robotic surgery. In certain countries, they'll buy the $2 million robot, but then have generic instrumentation that will hopefully work in that robot. What's always been interesting to me is that if car factories work 24 hours a day, manufacturers work 24 hours a day. So if you're going to spend $2 million on one robot, why does it only work from 7:30 in the morning to 4 p.m. in the afternoon? And when I was in China, I saw that they have different teams. So you have the day team, you have the afternoon team, and you have the night team of surgeons. And when I was speaking with folks at Intuitive, there are robots that work the most hours per month, for example, are actually in China. So that's a different mindset. So we're very, very privileged here that as surgeons, we work a certain shift. We work most of the time during daylight hours for elective cases. And the same thing with the robot. But that does not have to be. You can maximize your capital expenditure by making it work 24/7. Second is that if you're a healthcare system, a national socialized healthcare system, public system, maybe you don't need to have the exact same replication of technology in all your centers. It may cost you some political capital to make that decision, that tough decision, and there will be bickering. But maybe you only need to put the robotic systems in certain places, and the surgeons would then have to come to this area. But the last thing is that maybe you don't need to have, let's say you do have rural, let's say in northern Quebec, closer to the Arctic Circle, so you may have one robot there, but you can't have a thoracic surgeon there the whole time. So you have one general surgeon, for example, and then when he or she needs help for certain types of cases on that robot, then they can get help by having telesurgery. So you keep all the different specialists and in the bigger centers, and you just have the robot to do the different cases with the surgeons being remote. So those are some ideas in terms of cost. In terms of cost, the cost to be bared is different pressures, whether we're looking at a public healthcare system versus a private healthcare system. And I think from the public healthcare system, what I always mention is that it's important to learn from other systems. Very often, it's the private system that's going to have, just like in the United States, for example, it's the private system that has more robotic technology. And in other countries, for example, in Mexico, when I've been there, the private hospitals around Mexico cities are the first ones to get the robots. But then if the public system is going to adopt it, then why not go and learn from other people's mistakes? Why not get the data? And the data may not be extractable or usable for their system, but they can still learn from it. There's a track record. Avoid other people's mistakes. The other thing, in terms of different ways of thinking about it for a public system, is that you can have differential pay. So you can have a robot, and you make individuals who can afford it pay for it. And the profits that you make from that then can fund other patients who may not be able to afford it. Lastly, as Dr. Sachs mentioned yesterday, you can have a joint venture. Private companies, industry, will find some benefit to having the robot perhaps in your academic center, because they can do innovation if they're partnering with your engineering, with your computer engineers, with the other academics that are in your hospital. Second thing is that these companies need to have data, generate data, and they don't have patients. And the small private hospitals that have deeper pockets don't have the large number of patients. But it's the large public hospitals, such as, for example, Singapore Hospital yesterday with their almost 2,000 beds, they're the ones who have the patients. And that is something that's very valuable to a new technology company, to a new robotic company that's coming on market, because Intuitive's not the only one on the market for long. So that could be where the public system can leverage what they have with private companies and maybe have the robots land in their system for free. But how about for a smaller private system? In fact, when I was in Lebanon, for such a small country of 4 million people, there's quite a few robots. There's 5 robots. They're all owned by small hospitals. And why is that? And why are they doing it? Or why do some of them find barriers but overcome that barrier? Because they find if they're a small hospital in a private system, there's a lot of competition for that small number of patients in a certain country that can afford it. So that small group of patients, we always look at, well, how rich is that country? What's the GDP per capita of that country? And that's certainly one way of looking at it. But a different way of looking at it, and I know some of you who are trying to do international medicine for your US centers don't look at it that way. They see what percentage of rich patients are in that country. How many, for example, yesterday, how many millionaires are in that country? And there's a small group, but there's a sizable. But they have options among the different private hospitals. So these private hospitals feel that local market competition. And these types of patients who are wealthy in developing countries and low and middle income countries are just as demanding, if not more than demanding, than US patients. Lastly, another way of looking at it is a loss leader, meaning that it gets the patient in the door, but then that patient needs an MRI, that patient is going to need medication, that patient is going to need to have an angioplasty done. So that's a loss leader, and that's how some of the private hospitals have to look at it. And lastly is that for medical tourism. So patients who are in Syria, patients who are in Iraq, patients who are in other countries who have the means, but it's difficult to get to the US, it's further, they're having visa issues, it's hard for family to get there, there's a language barrier. Well, then they can go to a country, a neighboring country that does offer it, for example, in my example, in Lebanon. So there is medical tourism that could be a useful reason to have a robot. So these international patients are then funding your local patients. But cost is not the only thing. Over time, maintenance is a big cost. And some of the maintenance issues I've encountered when I've been to different places is that the robot breaks down, and if you're in the US, and now more recently in Europe, then Intuitive sends their engineers and they get there and they help you. But in many, what they call secondary markets, they have local distributors. So some of these distributors, for example, in Mexico and Lebanon, are just, a family that distributes orthopedic implants, and they distribute the robot, and they distribute this, and then they make the sale. That's where they make the most money, and then they don't offer the aftercare. So that's a problem. But that is changing because these companies are now going directly. Or number two is that you need to form an engineer who can maintain the robot. But lastly is that, as I mentioned, that software being online, just like your Tesla, you can get a lot of updates. They can figure out what's wrong with the robot virtually. So that is a barrier that is being broken down slowly. We talked about slightly geographic access, so some of the barriers. So you have to decide that maybe you don't need to have robotic systems in the whole country. Now, it's hard to do that, for example, in a system in the United States, which is a big private system, because it's hard to control hospitals. But in certain systems where the majority of the healthcare is being done in a public system, then the politician, the healthcare minister, the administrators, it's much easier to make those decisions, and that's important. And telesurgery, as we already talked about. But the third barrier can be, the third way to break down that geographic access is it reminds me of some hospitals, I would say 20, 30 years ago, they not all have MRI machines. And I remember that in the parking lot, there's an MRI truck. And then the MRI truck comes by every Friday. So if you need an MRI, we'll line up your patient because the truck's going to come and dock in receiving in the back, and shipping and receiving, and then you bring the patient in the MRI truck. Why was that? It's an expensive new technology. Nowadays, I don't see any MRI trucks. But why can't we do the same thing with the robot? The robot is not that, it does take space, but you can certainly have an operating room in the back of a big truck. So that truck can go from place to place and do robotic surgery. So you can maybe have a leasing program or whatnot. But the last barrier to adoption is training the surgeons. And this is where I'm going to spend a bit of time going through my personal experience with it and what are the lessons that I've really learned from training surgeons. So I think that we need, the first thing is that training, especially the vast majority of my training was in the United States at first, and now mostly turned to Canada, France, and some of the Middle East. And what I find is that we need to start shifting away from training where it's sponsored by the industry, because there's certainly conflict of interest there. But having maybe organizations such as the ICS putting a stamp of approval on certain surgeons training others, or providing that capacity where some of our colleagues in other countries can call on us and say, we need our surgeons to be trained in robotic prostatectomies. Can you send anyone? Do you have anyone? Can you put us in contact? So I think that training should be shifting from it being done by the industry to being done by either academia or medical societies. And then trainers need to be accredited, in my opinion, because just like not all surgeons have the same knowledge or capacity, same thing, not all the proctors have the same capacity or passion or ability to do it. And a lot of times it gets done because you're, especially early on, if your institution bought 2 robots, the company will reward, so to speak, the person who helped get the robots in and say, well, why don't you go and do some training and we'll pay for it and become a proctor. But I think that you need proctors that are dedicated, that put their time into it, and so an accreditation, somewhat accreditation program would be good. There could be some traveling fellowships. So these surgeons that want to learn robotic surgery can come and spend some time. I know the American Association of Thoracic Surgery has created these fellowships, but other societies can create these fellowships. And lastly is that teleproctoring is something that is going to be coming, and it's going to be very useful. So what are some of the lessons that I've learned? some of the things to do and some of the things not to do. So the first thing, I'm going to start with what I've learned I should do and I should continue improving on, is to meet with the surgeon and listen to what their goals are. Some are early on in their practice, some are later on. Some have already dabbled in robotic surgery, and they just need a few certain pointers. Some want to do it some have specific questions. It's important, as Dr. Vigneswaran said, is to review the cases in advance and not show up on the morning of and then decide. Maybe after speaking with that surgeon on the phone or by WhatsApp chat, you realize that maybe this first case that they want to do is not an appropriate case for where they are in their learning curve. Or maybe maybe they're a surgeon who mostly, for example, I'll just give you a personal example, mostly does cardiac surgery, and then they have a push that they want to do more lung resections for X, Y, or Z reasons, for financial reasons, in a private system. And then they tackle a case that may not be necessarily the right case to do robotically or even to be resected, for example. So it's important to review the cases. And then to set reasonable expectations. So because you have to set them up for success. And I think it's not only important for the patient to have a good outcome, but it's also important to leave and for the whole team to have a good outcome, meaning that they leave and they feel that the case went well, they feel that robotic surgery is positive, that we did not have conversions, we did not stay there until 9 p.m. to do one case. So I think it's important to set expectations based on that particular surgeon and based on the particular case he or she wants to do. And then you have to be you have to have emotional intelligence as a proctor, because there's different circumstances. If you go and you're proctoring somebody who is a very senior surgeon, and you're proctoring them in front of their junior faculty or in front of their staff, that they're very, very highly respected, and you come and you may be half their age sometimes, and you're proctoring them, it's very important to have emotional intelligence, that when you proctor them, they feel empowered, that they feel that they're still keeping the respect of people. And then even though something may not turn out exactly great, you need to downplay it, you need to spin it off a certain way, you need to use humor. And so you need to be very careful when you proctor somebody in terms of who they are, in terms of age, who they are in terms of respect level within the community, and who's watching them. Because little clues make a big difference. Don't sigh, don't feel like, show that you're getting impatient, because that shows off on their staff, and then they feel that the surgeon does not like the experience. It's also important to conform to operating styles and preferences. If a surgeon, just because you do, Dr. Vigneswaran mentioned it, just because you do a surgery a certain way, you like to use a cautery, and then the other person likes to use a bipolar, and they like to use a ligature or whatnot. Don't make them conform to the way you operate. You're there to provide a service. Everything is about the proctee, not the proctor. So you need to conform to their operating styles, and hopefully, as a good proctor, you've had a lot of experience. So if they want to put 3 ports versus 5 ports, and they want to put it from this side rather than that side, that's okay, because you're there to teach them, and you have to be experienced enough that you can take them through a case through any which way that they want, rather than making them do the way you do it. But that's when you first speak to them, you set those expectations and you ask them, do you already know what you want to do? If the answer is yes, then you conform to them. If they say, no, I want you to tell me how to do it, tell me everything, I just want to learn exactly the way you do it, then that's fine too. But you have to set those expectations and be able to conform. And then use, again, emotional intelligence, judgment. So judge the best teaching style for that person. Some people who are just finished training, then they're more likely to accept when you tell them, move your right hand this way, move your left hand this way, do it this way. Maybe that's not the artery, maybe that's not the vein. If you're teaching somebody that is more experienced, or somebody who has a certain ego, or somebody who was a mentor, somebody who, it does not matter. If you have to see how well do they respond to your teaching. And then maybe you should let them, sometimes you just need to tell them exactly what to do, but other times you just need to let them be and only give them advice when they ask for it. Or maybe only give them advice when you see that it's not progressing. And maybe make suggestions rather than tell them what to do. But some people, they just want to get, a recipe. Just do this, do that, do this. So I think you need to be a judge. So that's part of being a good proctor. Next is explain clearly the reasons why they may be having technical difficulties and suggest useful remedies. Not say, oh my God, why can't you just get around this vessel? Or lose patience. But rather say, maybe you're not getting around the vessel because your left hand is not putting enough tension. And so you have to, but in order to be able to make those comments, you need to have seen a lot of people making those mistakes. Then you need to look back at yourself and see what you're doing differently and trying out back in your home institution. And having a fellow is certainly helpful. And then you have to really break down each step and not say, I just get around it and I don't know how I do it. But you have to minimize that. You have to say, my hand goes this way, my tension is this way, my view is that way. And really decorticate every single step that you do that makes the difference. And you need to be able to articulate it in a clear fashion.
1 minute, Dr. Fontaine.
Okay, very good. And lastly is that you should not be a parachute proctor coming in just one time, but rather having a long-lasting, and it's really a two-way occasion. But don'ts in 1 minute is that don't assume that you know more than the proctee. Some of these surgeons have been around for a long time. Don't make them operate exactly the way you do. Don't push people past their technical limits. Some you can push, but you need to realize what is the limit that they have. Don't criticize their staff or the hospital or their healthcare system, what they have. Don't criticize the patients. Only make constructive remarks. Leave the operating room with a positive attitude. Never create a negative attitude. And then lastly, and I think that's very important, don't be dishonest in the evaluation when you leave. So a lot of times the sales rep from the company will be there, and then you can't say, well, this person, I don't think you should do a robotic procedure the next time, because they're not ready for it yet. So you have to be, and that's why maybe we need to dissociate the industry from the proctor. And lastly, don't leave and allow the sales rep to encourage people to take on cases that they can't. And that's it. So what have I learned in conclusion is that I've improved my teaching skills myself. It's allowed me to improve my own technical skills by seeing how others can make mistakes, some of the pitfalls. You learn from others' mistakes as well. It gave me a better understanding of the US and global healthcare systems. I learned a lot about other countries' healthcare systems. And I imported new ideas to my own institution by seeing how they do things in other countries, especially in Asia. And that's it. Finish on.
Okay, let's move on to our next speaker. We have Kathleen Campus from the University of Washington and Harvard U, who will be talking to us about forging a path to healing, bridging gaps in burn surgery access amidst adversity.
Good morning. Today I'm deeply appreciative to be present with you all, dedicated, wise, compassionate healers and innovators. Please join me in addressing a crucial issue that calls for our collective focus: access to burn surgery in austere environments. I have no disclosures. To start, let's review burn injuries, surgical access, and risk in austere environments. Next, we'll explore relevant training and quality improvement strategies. And finally, we will consider some key factors to support healthcare professionals aiming to improve burn care access in humanitarian settings. Over 2/3 of the global population lacks access to surgical and anesthesia care, leaving an estimated 5 billion people without acute burns care and surgical treatment when needed. Annually, the World Health Organization reports 11 million burn injuries worldwide, resulting in 100 to 350,000 deaths. Currently, burns ranks fourth among traumatic injuries and fifth among non-fatal childhood injuries globally. They are also a significant cause of morbidity, particularly affecting women, children, and socioeconomically disadvantaged individuals. Nearly a quarter of the world's population lives in areas ravaged by conflict or disasters, with 3.6 billion at high risk from climate change and natural disasters. Burn injuries are alarmingly prevalent in these regions, exacerbated by explosive violence, chemical exposure, destruction of infrastructure, unsafe living conditions, and fragile health systems, compounded by limited access to medical care and safety measures. Notably, more than 95% of the annual burn incidents occur in low-resource settings, and tragically, children represent 70% of these cases. In conflict zones, civilians endure 87% of war casualties, with burns comprising 5 to 20% of all conventional warfare injuries. Additionally, burn injuries may also represent 11% of surgical interventions within humanitarian contexts. Despite the profound need, research into burn injuries, addressing their prevalence, mortality, triage management, and the enhancement of care systems in these contexts remains sparse. The World Health Organization recognizes that providing care in austere environments is fraught with complex challenges. Fragile relief systems in healthcare, critical delays in urgent care. Resources are scarce, environmental and infrastructural perils are heightened, and the local medical workforce, while determined, often lacks the necessary specialists and facilities. The absence of tailored guidelines and resources for burns care further complicates the scenario. Such factors severely hamper timely access to burn care and hinder the efficacy of emergency medical responses, an issue underscored by experts like Jen and Jacques, as the included table demonstrates. Leading organizations like the International Society for Burn Injuries and Interagency Standing Committee advocate for better burn surgery and care access in humanitarian contexts, supported by resolutions like WHA 74.9, aiming to strengthen surgical care within global health emergencies. This unified stance underscores the vital need to elevate global burn care standards. The pressing reality calls for concerted action to enhance healthcare in vulnerable areas, highlighting the crucial role of global collaboration and support. In pursuit of comprehensive insights to enhancing burn care in austere environments, I conducted a systemic review spanning the past 2 decades, identifying access gaps, analyzing improvement interventions, and evaluating stakeholder capacity building for a detailed overview of the current landscape. A total of 16 reports were selected for inclusion, and 3 key domains to bolster interventions were identified, including surgical training, workforce support, and capacity building. Navigating burn injury epidemiology in austere environments presents multiple challenges due to its diverse causes, treatment methodologies, and incidence patterns. These challenges are compounded by the scarcity of data, as well as variable resource and support constraints. Nevertheless, in humanitarian settings, burn injuries primarily result from explosive violence, chemical weapons and exposure, electric shocks, thermal and radiation exposure, infrastructure and environmental hazards, unsafe behavior, abuse, and violence. Standard burn care practices and surgical techniques are crucial, yet adapting to the unique challenges of treating civilians and supporting clinicians in humanitarian settings is essential. A pivotal 2022 systemic review by Sandhu and colleagues illuminates the necessity of structured pre-hospital care. Their flowcharts delineate the urgent need for early specialist intervention in complex burns and underscore the paramount importance of comprehensive education for providers. Equally critical is preparedness and allocation of resources, as emphasized in the 2023 study by Serkesi and Demiroz on burn injuries post-disaster. This study reports a notable prevalence, citing about 10% of serious injuries from 2021 Haiti earthquake were burns. The study's emphasis on prompt and correct treatment and surgical interventions supports the call for robust, ready-to-deploy burn care systems to address humanitarian crises effectively. We recommend expanding burn specialty training to include local surgeons as well as non-surgical healthcare providers, EMT, military, and humanitarian teams. Key strategies involve the deployment of comprehensive burn management training, EMT and trainer courses, relevant online and resource tools, community education and engagement, prevention programs, and global partnerships. Effective training programs and tools have become vital for enhancing burn surgery in resource-scarce areas, revolutionizing patient care through technology and education. For instance, MSF telemedicine has connected 500 burn specialists globally with local caregivers, cutting the need for medical evacuations by 40%. MSF training has also trained 2,000 healthcare workers in burns care, significantly improving care quality in underserved areas. The 2020 American Burns Association Burns Care in Austere Environments Guidelines highlight the need for disaster preparedness in burns care, advising on assessment and resource management. They focus on surgical priorities based on burn severity, offering a triage decision table, and covering essential care aspects like airway management and fluid resuscitation, emphasizing the efficient use of scarce resources. Meeting the needs of this underserved group requires a collaborative effort among key stakeholders: surgeons, anesthesiologists, emergency and critical care personnel, and ancillary healthcare staff through a unified, comprehensive, all-hands-on-deck approach. Of the reports analyzed, 85% endorsed initiatives focused on reciprocal learning exchange, streamlined stakeholder mobilization, and advancing multi-systemic implementation. These efforts span from strengthening the local and humanitarian surgical workforce to implementing tailored protocols for optimized burns care. Moreover, there is a resolute prioritization of delivering palliative and end-of-life comfort care, devising a comprehensive continuum of care response, and establishing protocols for managing distress, peer support programs, and leadership support for workforce members, all tailored to the resources, personnel, and infrastructure available. In the realm of resource optimization, a 2023 study by Jones and researchers serves as a compelling example for burn care planning and surgical team enhancement. it scrutinizes the use of internal resuscitation through oral rehydration solutions, ORS, as an innovative approach for managing burn shock in austere settings. By highlighting the logistical hurdles tied to traditional IV fluid therapy, this research suggests ORS as a potentially more viable and resource-efficient alternative. This strategic shift not only confronts logistical challenges, but also emphasizes the critical need for adapting medical treatments to the demanding realities of battlefields, disaster sites, and remote areas. In parallel, a prime instance of workforce support is illustrated by the concerted efforts of MSF, ICRC, WHO, and UNICEF in Gaza, particularly in aiding surgeons and healthcare professionals treating civilians affected by burns and trauma. Interdisciplinary humanitarian medical teams offer essential medical and psychological support to the local workforce, encompassing surgery, therapy, education, and psychosocial assistance, critical in a healthcare system burdened by conflict and blockades. In tandem, agency directors advocate for unimpeded access and infrastructure protection to facilitate effective healthcare delivery.
1 minute.
To enhance capacity building for burns care, we recommend 7 key components that catalyze collaboration and spur innovation, including efforts to support the implementation of a global burn registry for comprehensive data tracking, advanced research in epidemiology, burn injury, and surgical outcomes, form centers of excellence, learning hubs for cutting-edge training, broaden the scope of burn care from frontline to tertiary management, enhance civil-military coordination for integrated response efforts, forge collaborative alliances across stakeholders for unified action, establish context-specific, resource-optimized burn care standards, and endorse global health policy and advocacy. Our community has demonstrated exceptional flexibility in administering burn care under challenging conditions. Application of such strategic pillars have transformed global burn care, ensuring effective, coordinated, and innovative treatment in humanitarian crises, such as within Syria's conflict zones through dedicated conjoint efforts, Interburns burn-free village movements in Nepal, and throughout the refugee camps in Bangladesh. These efforts demonstrate that effective burn care is achievable even amidst resource constraints, highlighting the resilience and ingenuity of healthcare providers in conflict and disaster settings. In summary, there's a significant gap in research on burns care in the humanitarian context, highlighting the urgency for advancements in surgical training in austere environments. Lastly, our study aims to shed light on the remarkable effort and progressive outcomes of our community, both locally and globally, in the face of humanitarian crises. We recognize the reality that not all can be saved. However, the necessity is twofold. Our patients require compassionate care, and our frontline workers deserve our unwavering support. They stand resilient, saving lives and offering solace amid adversity, even in moments when comfort care is all they can offer. Our efforts must also acknowledge this resilience and dedication. Now is a time for action. By standing together, you and I embrace the advancement of burn care in humanitarian settings, and to provide support to those who deliver it, paving the way for a future where every hand extended in help is held up and strengthened by another. Thank you for your presence today.
Thank you very much. Let's move on to our next presenter. Is Dr. Mary Hunter from